For the appropriate patient, that is a patient with intermediate 1 but has symptomatic splenomegaly, or for a patient with higher risk disease such as intermediate 2 or high risk, I typically will initiate ruxolitinib. It's important to look at the platelet count. As patients with severe thrombocytopenia, this can be a problem, but there are dosing guidelines dependent upon the patient's baseline platelet count in terms of initiating ruxolitinib and then titrating the dose appropriately. So that needs to be thought of very accurately before initiation of ruxolitinib. But what I expect when I initiate ruxolitinib on an appropriate patient is reduction of the size of the spleen, and I will use that as an assessment of response. But more importantly, how is the patient feeling? If a patient's having night sweats, these should be abrogated. If a patient's having fevers or pruritus, I would expect these to be improved. Sometimes patients want to please the physician and may overestimate their responses. And then again, this goes back to the total treatment score, where you can objectify the patient's baseline symptoms and then follow it with time to see objectively how the patient is feeling. Myelofibrosis is a chronic disorder, and patients can succumb to the disease on a multitude of avenues, unfortunately. If left untreated, continued constitutional symptoms leading to weight loss, deconditioning is often a mode of exit. Patients can develop thrombosis. This is typically reserved for patients with preserved platelet counts or even thrombocytosis, which is a subset of patients with primary myelofibrosis. Complications of splenomegaly, splenic sequestration, early satiety. Again, many of these symptoms can be ameliorated with ruxolitinib, but not all. There is a small role for splenectomy in patients who have refractory disease, who are surgical candidates. And unfortunately, about 15 to 20% of patients may transform into acute myeloid leukemia. Unfortunately, even currently, we don't have good stratification and good disease modifications for patients who have transformation to acute myeloid leukemia. For suitable patients who have a good performance status, who are young age, the treatment strategy is often induction chemotherapy with transplant. But unfortunately, myelofibrosis is a disease of the elderly, and many patients couldn't tolerate induction chemotherapy and transplant. So a lot of these issues are age-based. There are a lot of new therapies that are being explored for patients with myelofibrosis. There are other JAK inhibitors that are being tested against ruxolitinib. These have been reported and presented at ASH 2016 and again at ASCO 2017, trying to compare their efficacy to ruxolitinib. Ruxolitinib is a higher than expected bar. Ruxolitinib is a drug that has mild disease modifications in terms of improving outcome, but it turns out to be a high bar to overcome. There are other strategies in terms of anti-fibrinolysis. PRM-151 is being developed, imeltelset in a subset of patients who have splicing factor mutations. So there's a wide range of therapies directed against the disease that are being explored. Then there's another set of therapies that are trying to augment and improve the anemia that's often associated with this disorder. So there's lots of venues that are being pursued. Most importantly, what I see the biggest development over the last year or two is understanding the biology, getting at the genetic makeup. What are the disease-initiating events? And by better understanding that, we're going to have better therapies in the future.